Ischemic heart disease is one of the most important topics for any medical professional to understand, but keeping all the types of angina and myocardial infarction straight can get tricky. In this video, I'll help you build a clear, high-yield foundation on this topic, all in just 4 minutes. Ischemic heart disease, or IHD, occurs when the heart muscle doesn't get enough oxygen to meet its needs. It's one of the most common causes of death worldwide, so understanding its types and mechanisms is essential. IHD can be divided into chronic and acute types. Chronic forms include stable angina and Prinzmetal angina, which result from fixed atherosclerotic plaques or transient coronary vasospasm, respectively. Acute coronary syndromes, or ACS, result from sudden plaque rupture and thrombosis. These include unstable angina, NSTEMI, and STEMI. Let's review all of these types now. Prinzmetal angina is caused by a transient spasm of the coronary artery. It typically happens at rest and causes transient ST elevation. Symptoms resolve with vasodilators like non-dihydropyridine calcium channel blockers, so verapamil or diltiazem. These can be given with or without nitrates. Avoid beta blockers because these may worsen vasospasm. In stable angina, a fixed atherosclerotic plaque reduces blood flow. Symptoms occur with exertion when oxygen demand rises, but are relieved by rest or nitroglycerin. On ECG, you'll see ST depression due to subendocardial ischemia. Troponins are normal, though, because there is no cell death. Treatment focuses on symptom control and risk reduction, so lifestyle modification, nitrates for relief, beta blockers, calcium channel blockers if needed, and antiplatelet therapy, usually aspirin. Statins are used to slow atherosclerotic progression. In acute coronary syndrome, a plaque ruptures, triggering thrombus formation and sudden ischemia. The type of ACS depends on the degree of vessel occlusion and whether necrosis occurs. This is the mechanism behind unstable angina, NSTEMI, and STEMI. Unstable angina occurs when a plaque ruptures, but the thrombus does not completely block the vessel. Patients experience chest pain that does not improve with rest. ECG can show ST depression or T-wave inversion, but troponin is going to remain normal since there's no myocardial necrosis and no cell death. Treatment includes hospitalization, antiplatelet therapy, so aspirin and a P2Y12 inhibitor, anticoagulation by heparin, beta blockers, nitrates for symptom relief, and sometimes early percutaneous coronary intervention, PCI in the cath lab, if high-risk features are present. The difference between NSTEMI and STEMI lies in the extent of occlusion. NSTEMI is a partial occlusion, causing subendocardial necrosis and ST depression. STEMI is complete, causing transmural, so across the entire wall, necrosis, and ST elevation. Both elevate troponin, but STEMI usually has higher levels. Treatment for NSTEMI is similar to unstable angina. Antiplatelets, anticoagulation, beta blockers, nitrates, and risk-stratified early PCI. Treatment for STEMI focuses on rapid reperfusion. Primary PCI is preferred if available, or fibrinolysis if PCI is delayed, along with antiplatelets, anticoagulation, beta blockers, ACE inhibitors, statins, etc. Here's a high-yield summary of what we talked about today. Feel free to screenshot this and cover up the different parts to quiz yourself on later. To wrap up, ischemic heart disease is all about a mismatch of oxygen supply versus myocardial demand. The various forms differ in cause, EKG findings, and troponin patterns. Understand these distinctions and you'll have a great foundation in ischemic heart disease. Thank you so much for watching. Be sure to like, subscribe, and share with your friends if you found this helpful. Also, comment any future videos that you'd like to see. Thank you so much and happy studying.